Good afternoon, everyone. My name is Molly Howell, and I'm the Immunization Director for the North Dakota Department of Health. And today I'd like to welcome you to our town hall regarding pediatric COVID-19 vaccine and boosters for adults. We have a number of great presenters and participants on our town hall today, so I'll start off by introducing them. First, I want to introduce Grace Njau. She is the North Dakota Department of Health Special Projects and Health Analytics Division Director. Also from the Department of Health, we have Brenton Niesmeyer. He's our Field Services Division Director in the section of Disease Control. And then we have some external partners that are joining us today. And so first I want to introduce Dr. Joan Connell. Dr. Connell works as a pediatrician in Bismarck at the University of North Dakota Center for Family Medicine, as well as serving as the teen pediatrician for Children's Regional Asthma Clinic. She completed her pharmacy degree, master's degree in biomedical research, master's degree in public health, and Doctor of Medicine degrees at the University of Colorado. She is a past president of the North Dakota chapter of the American Academy of Pediatrics and current council member for the North Dakota Medical Association. Dr. Connell is married and has 3 children and loves to be a soccer cheer mom in her free time. And then also with us, we have Dr. Avish Nagpal, who did his internal medicine residency at the University of North Dakota Merit Care in Fargo, an infectious disease fellowship at Mayo Clinic in Rochester. Following that, he returned to Fargo in 2013 and has been working at Sanford as an infectious disease physician and medical director for infection prevention. And so to start us off, I'm going to turn it over to Grace, and she's going to talk about COVID-19 illness in children in North Dakota and the United States. And then after that, I'll present a bit on some immunization recommendations, and then we'll have a chat and an opportunity for Q&A. So I will turn it over to Grace.
Great. Thank you, Molly, and thank you everyone for being here this afternoon. And so I will get right into some of the data around COVID-19 in children ages 5 through 11. And so what you're looking at here is the distribution of the monthly rates of the 7-day rolling averages, or at least case rates of children ages 5 through 11. And so through October 27th of this year and over the course of the pandemic, we've had 8,841 cases diagnosed in this population. Out of those, we had 22 hospitalizations and 5 cases of multi-inflammatory syndrome in children that have been reported. And fortunately, we have not had any deaths reported in this population. And then in terms of the academic calendar, so the same data just presented as cases over the 2020 through 2021 school year, and then the 2021-2022 school year. You do see that in the 2021 through 2022 school year, we have way more cases, and those are the ones in the orange for active cases. And some of this is, of course, driven by the higher transmissibility of the Delta variant, but overall, we do see more cases diagnosed this year compared to the previous year. And then nationally, because, while we have the North Dakota data, I think the national data does provide some depth in terms of what else has been going on with this population. You do find that overall 562 cases of hospitalizations occurred in this age group. And the median age of the children who were hospitalized with COVID-19 was 8, and majority of them being male, about 57% of them. But you do see that minority children, the Black, non-Hispanic, and Hispanic children were a little bit higher in terms of the rates of hospitalizations at 37 and 31% more being hospitalized in that population. Unfortunately, about 32% of children had no underlying healthcare conditions, which is of course quite concerning. And the two most commonly reported conditions that led to hospitalizations in addition to the COVID-19 were the chronic lung disease, primarily asthma, and then obesity as well. And then overall, we've had 94 COVID deaths in this age group, the 5 through 11, and this does represent about 2% of all the deaths that occurred in the US children of that population. And then going back to MIS-C, this multi-system inflammatory syndrome in children, what you do find is that this does occur about 2 to 6 weeks after an acute COVID-19 infection, and it can result in a wide range of clinical manifestations and complications. And it is estimated that you do see about 1 case of MIS-C in approximately 3,200 COVID infections, and 60 to 70% of these patients are actually admitted to intensive care, and about 1 to 2% of them actually end up losing their lives. And so in national surveillance, what we found is there were about 5,217 MIS-C cases that were reported between February 19th of 2020 through September 23rd of 2021. And the median age in this, in these cases that were reported was about 9 years of age. And 44% of these cases did occur in children who were 5 through 11. And once again, you do see that minority children, especially that Hispanic, Latino group, and then the Black non-Hispanic children were more likely to be overrepresented in this at about 61% of the cases that were reported. And of those, I believe there are about 46 MIS-C deaths that occurred, and 9 of those occurred in children who were 5 through 11. And so looking ahead and also in sort of like thinking about what some other post-COVID conditions in children are and additional risks that may be associated with COVID-19 in children in this age group, you do see that, while COVID does appear to be less common than, post-COVID conditions do appear to be less common in children than in adults. In a study out of the UK, they did find that about 7 to 8% of children who were diagnosed with COVID-19 ended up having continued symptoms about 12 weeks after a diagnosis. And so these post-COVID conditions may appear after a mild or severe infection or even after MIS-C. And some of the most common reported symptoms, these are very similar to some of the meta-analysis that has been done on adults. And you do find that fatigue, headache, insomnia, trouble concentrating, pain, and coughs do seem to be the more persistent symptoms that appear in post-COVID conditions, I guess, as a post-COVID condition. And then, of course, that does translate into some loss in terms of the quality of life. And this could be, limitations in physical activity, emotional distress, mental health challenges, and of course, decreased school attendance and participation. So we do know that, through our investigation process from, data nationally, globally, that, transmission is quite efficient among children and adults. And I think there is this one example from an mortality and morbidity UK report that was published back in August, where he did find that, an occasionally unmasked adult who was infected with the Delta variant was very easily able to infect 50% of a classroom, so 12 of 24 kids that were in this classroom. And so schools can definitely help stop the spread by ensuring that everyone is, wearing their masks correctly, staying home if having symptoms, testing routinely, and now that we have this vaccine available to the 5 through 11, getting vaccinated once you are eligible. And so in summary, as I mentioned, children are very much as likely to be infected with COVID-19 as adults, and children are at risk of severe illness. And while we do not have any fatalities, as I mentioned, we did have at least 22 hospitalizations in North Dakota. And these hospitalizations, nationally, at least with the 8,300 hospitalizations, they do seem to be very similar to what you'd see in they do seem to obviously supersede what you would see in pre-pandemic influenza seasons. However, the severity in terms of COVID-19 and the flu does seem to be about the same in terms of who requires ICU admission. And so that is all I have, and I will turn it over back to Molly. Thank you, Molly.
Thank you, Grace. Great summary about the impact of COVID-19 on children ages 5 to 11. And so now I'm going to present what the vaccine recommendations are for children in this age group. And then I'm briefly going to discuss boosters for adults, because since the last time we had our town hall, booster recommendations have occurred. And so I just want to make sure, can everyone see my slides okay? Yeah, okay. So when you're thinking about whether or not to vaccinate your child, it's not just, should I take the vaccine or not? You're really making a decision, and it's a risk decision about, do I want to risk taking the vaccine, and do I want to risk the virus? And so today I really want to make sure that we provide parents with information on how they can make an educated decision regarding vaccination. And so, as been probably advertised pretty heavily in the media lately, but we do now have a pediatric vaccine for children ages 5 to 11. The Pfizer COVID-19 vaccine was authorized by the FDA last week. Their independent advisory committee voted 17-0 with one individual abstaining to recommend that FDA authorize the vaccine. FDA did authorize the vaccine, and then CDC's independent advisory committee, the Advisory Committee on Immunization Practices, voted 14-0 on November 2nd to officially recommend the vaccine for children, all children 5 to 11. And then additionally, the CDC, American Academy of Pediatrics, and the American Academy of Family Physicians all are recommending that all children 5 and older be vaccinated against COVID-19. The vaccine was authorized based on a clinical trial that was conducted by Pfizer. 4,600 participants were included in the clinical trial. They were randomized 2-to-1 to receive the vaccine versus placebo, meaning not receiving the vaccine. And so a little over 3,100 participants received the vaccine, over 1,500 received placebo. The vast majority had 2 months post-safety follow-up. The vaccine was found to be highly effective at more than 90% at preventing symptomatic COVID-19 illness, so having symptoms consistent and testing positive with COVID-19. There were no cases of severe COVID-19 in the clinical trials, so no deaths, no MIS-C. The vaccine was found to be highly effective against the Delta variant, so the clinical trial occurred over the summer, and the majority of the cases that were sequenced were the Delta variant. And then one thing to note is that the pediatric Pfizer vaccine is different than the formulation for those 12 and older. It's about 1/3 of the dosage that older children and adults receive. So in the clinical trial, they do monitor participants for side effects, and the side effects of the pediatric vaccine were mostly mild to moderate, and very similar to what's being seen in older children and adults. So chills, fatigue, fever, headaches, diarrhea, muscle aches. Actually, the side effects reported in the 5 to 11 age group were less than what was reported in those 16 to 25. There were no serious adverse events due to the vaccine that were identified in the clinical trial. And then one thing to note is that, and this is true for all age groups, is side effects tend to be more common after the second dose than the first. So one thing that I do want to talk about is myocarditis, which is an heart inflammation or inflammation of the muscle around the heart. There were no cases of myocarditis identified in the clinical trial, but again, the clinical trial was small, about 3,100 participants received the vaccine. But the myocarditis has been linked to mRNA vaccines, including the Pfizer and Moderna vaccine in older individuals. So the highest reported rate of myocarditis after vaccination is in the 16 to 17-year-old male age group at 69 cases of myocarditis per 1 million doses administered. Myocarditis does appear way more common actually in males than females. And also at the Advisory Committee on Immunization Practices meeting, data were presented showing that myocarditis is more common in older individuals with the Moderna vaccine than the Pfizer vaccine. It does appear that vaccine-induced myocarditis is more mild than that caused by illness. So myocarditis can be caused by viral illnesses, including COVID-19, and it does look like myocarditis is more mild, although it still is something to be concerned about because the vast majority of individuals with myocarditis are hospitalized. So I do want to touch on, and the reason why we talk about weighing your risk is that most likely everyone will get COVID-19 or be vaccinated. And so there's not really going to be an in-between where if you're not vaccinated, you're not going to get COVID-19. So when you're making the decision about vaccination, you have to weigh what your risks are with COVID-19 illness. And myocarditis occurs at a higher rate after COVID-19 illness. If we look at the 12 to 17-year-old age group, and this is a preprint study, I've provided the link here, but there's other studies from Israel and the New England Journal of Medicine, and also in Morbidity and Mortality Weekly Report. But the highest rate is 876 cases of myocarditis per 1 million males infected between the ages of 12 and 17. And so you can see that the rate is much higher of myocarditis after having COVID-19 illness than after vaccination. And in fact, in the study, they say you're 6 times more likely to have myocarditis post-infection than after vaccination. Now, granted, all of these rates are in older individuals, and no myocarditis cases were identified in the clinical trial for the vaccine for 5 to 11. So we don't yet know if myocarditis will occur in the 5 to 11 year age group once we start vaccinating more individuals. But there are a lot of suspicions that because the baseline rate of myocarditis in the general population is lower in the 5 to 11 age group, that it's very likely if myocarditis does occur, it's going to occur at a lower rate than it does in the adolescent age group. In terms of long-term side effects from the vaccine, this is a question that often comes up. And obviously this is a new vaccine, and so it's understandable for parents to have questions about long-term side effects. But based on what we know of mRNA vaccines and the ingredients and the experience we've so far had with mRNA vaccines, and then just all the experience we have with other routine vaccines in the United States, long-term side effects are not expected. The vaccine ingredients are cleared from your body almost immediately, very quickly. COVID-19 virus is not in the vaccine, it's just the spike protein. For all other vaccines that we've used in history, serious adverse events generally occur within 42 days post-vaccination. And so we've already given more than 248 million Pfizer doses in the United States and have a really good sense of what the safety profile is of the Pfizer vaccine. And you also have to weigh the long-term side effects of COVID illness, which Grace touched on some of them, but it does include myocarditis, 6 to 7% of kids having long haul symptoms, and a lot of side effects that we don't even know about yet. And so really when you're considering vaccination, you can't just take into consideration the risk of an adverse event, but you also have to take into consideration the potential for side effects from COVID illness, including long haul COVID. So the Advisory Committee on Immunization Practices, when they make a decision whether or not to recommend the vaccine, that's exactly what they do. They weigh the risks from the disease and then the risks and benefits of vaccination. And so this is a slide that was presented at their November 2nd meeting. And on the left, you can see if we started vaccinating 5 to 11-year-olds for every million vaccinations administered, based on the current epidemiology of COVID-19, we would prevent over 58,000 cases, 226 hospitalizations, 132 MIS-C cases, and 72 admissions to the intensive care unit. Now, right now, we do have higher transmission of the Delta variant. And so on the right, it shows over time taking the average for the pandemic of case rates and kind of smoothing out the curve. And even with lower rates calculated in for COVID-19, we still would prevent over 18,000 cases, 80 hospitalizations, 42 cases of MIS-C, and 26 ICU admissions. And this is just for every million doses administered just to that 5 to 11 age group. So I've kind of talked about the risks of COVID-19 vaccine, but I just want to summarize a lot of the benefits. The benefits of pediatric COVID-19 vaccine include, of course, preventing illness, hospitalization, and death. We know in individuals 12 and older that COVID-19 vaccination has been responsible for preventing a significant number of cases of especially hospitalizations and deaths, including cases of mild illness as well. These vaccines will prevent long-term COVID symptoms because you're going to be less likely to have COVID, prevent transmission to vulnerable loved ones and community members. Getting your child vaccinated will avoid them having to miss school because they're ill or they're a close contact to somebody who had COVID. And then they can avoid missing other activities which are crucial to their social well-being, including sports, music, and social activities. We do already have the Pfizer Pediatric COVID-19 vaccine in North Dakota. North Dakota ordered and has been receiving, and I think as of today, I've received all 18,000 doses of our initial order of the Pfizer COVID-19 vaccine for children 5 to 11. But we can order additional doses as needed. We've already heard of some providers running out. Parents have been very interested in receiving this vaccine. There are about 82,000 children in North Dakota between ages 5 to 11. Vaccine has been distributed to 214 different locations throughout the state, including local public health, pediatrics, family practice, community vaccinators, and pharmacies. And to find vaccine, parents can go to vaccines.gov. And actually, as of this afternoon, it is available where you can search for pediatric vaccine for the 5 to 11 age group and find a provider near you. And so now that I've touched on the pediatric vaccine, I just wanted to talk about boosters because there's been some changes since the last time we had a town hall. And so, first of all, I just wanted to mention why boosters are needed. COVID-19 vaccines have done a very good job at preventing cases, and they continue to prevent hospitalizations and death. But vaccine effectiveness against infection, meaning having symptoms of COVID-19, is decreasing with time and due to the Delta variant. And so, although vaccine effectiveness does seem to be holding up well for younger age groups at preventing hospitalization and death, it definitely has been declining, especially in those 65 and older. And then vaccine effectiveness for the Johnson & Johnson vaccine, which was initially recommended as a single dose vaccine, does appear lower than that for the two mRNA vaccines, Moderna and Pfizer. Boosters aren't something that's unusual in the vaccine world. All of us, if we've been vaccinated against polio, if you look at your record, you probably have 4 or 5 doses of polio vaccine. We're all recommended to have tetanus vaccine every 10 years. And so sometimes vaccines need boosters, and with COVID, that's definitely what's happening, that in order to be protected against COVID illness, you probably do want to consider a booster. And so just to kind of look at what's happening in North Dakota, this is from our dashboard. This is updated daily. This is COVID-19 cases by week. In the gray are individuals who are not fully vaccinated, and in the orange are fully vaccinated individuals. The fully vaccinated does not include people who received booster doses. It's just people who received 2 doses of mRNA vaccine or 1 dose of the Johnson & Johnson vaccine and are 2 weeks post-vaccination. You can see that there have been increases in both the fully vaccinated and not fully vaccinated cases, but still, the majority of cases in North Dakota continue to be in those individuals who are not fully vaccinated. In fact, you're 5 times less likely to have COVID if you're fully vaccinated than not fully vaccinated in North Dakota right now. And then again, this is hospitalization data. Same thing, you're much less likely to be hospitalized with COVID, and I'm sure Dr. Nagpal can talk about this when we turn it over to him, than if you're not vaccinated. I also wanted to mention something that people will want to have on their radar. In epidemiology, we call it base rate bias or base rate fallacy, which is just a technical term that you can't just look at numbers of, let's say, breakthrough deaths or non-breakthrough deaths, so deaths occurring in people who are vaccinated. Sadly, we have had deaths occur in people who are vaccinated, but they're occurring at a much lower rate than in individuals who are unvaccinated And so if you just take a look, the last column here, or the last row here, we've had, this is through for 2 months, August to October 2021 in North Dakota. We had 87 breakthrough deaths, sadly, but 145 of our deaths occurred in people who were not vaccinated. And so you might think, oh, 87, that's kind of a large percent compared to 145, but you have to look at the rate. And so the rate of death in people who are vaccinated is 26.5 per 100,000 versus 62.2 per 100,000 in the unvaccinated. And this varies drastically by age group. I mean, if you go down to the 60 to 69 year age group, you can see that there's 17 deaths per 100,000 in the vaccinated individuals, but 170 per 100,000 in unvaccinated individuals. So I just want to make sure people aren't just looking at numbers. You have to look at what number that is out of the population. If you look at the 80 and older, you can see that technically more people have died in that 80 and older age group that were vaccinated than not vaccinated. But look at how small the unvaccinated population is. You're much less likely to die of COVID if you are vaccinated than unvaccinated. Another reason for boosters is if you look at Israel, you can see the impact that boosters have had on their population. Israel solely uses the Pfizer vaccine, and initially they rolled out boosters for their 60 and older population and have been slowly rolling that down to other age groups. But you can see since they introduced boosters, and this is out of 1.1 million people, this was published in the New England Journal of Medicine in September, but they've now seen a 91% vaccine efficacy against infection and 95% vaccine efficacy for severe illness. And so when we look at CDC recommendations for booster dose, if you initially received the mRNA vaccine, meaning if you received Pfizer or Moderna, people 65 years of age and older, those 50 to 64 with underlying medical conditions, or those 18 and older who live in long-term care settings or are at high risk should receive a booster shot at least 6 months after their second Pfizer or Moderna dose. And high-risk settings includes almost anyone. So anyone who lives somewhere where where COVID-19 could be spread where they work or reside. And the underlying conditions that are included is anything from cancer to diabetes to being overweight, substance use disorders, heart, lung, liver conditions, a variety of conditions. And then for the Johnson & Johnson vaccine, for people who initially received the Johnson & Johnson vaccine, you can see that people 18 years and older should receive a booster dose of the J&J vaccine at least 2 months after having received their initial dose of the Johnson & Johnson vaccine. Another thing that was recommended was mix and match boosters. And so this means the potential to use a different brand of vaccine for your booster dose. And so providers and patients now can choose which brand of COVID-19 vaccine to receive for their booster dose. And so we have a fact sheet on our website to kind of help you decide what you should receive or which brand you might want to consider. And you can also talk to your healthcare provider about which brand you might want to consider for your booster dose. There was a National Institute of Health study which showed safety and benefits of mix and match boosters, which I'm going to touch on right now. And so the NIH took about 450 patients and split them across 9 different study arms and looked at which booster might be the best depending on which initial vaccine you received. And so you can see for the top column is what the initial vaccine that people received. And so for Pfizer vaccine, the booster that appeared to increase neutralizing antibodies the best in this study was the Moderna vaccine. And so people who initially received Pfizer may want to consider a Moderna vaccine for their booster. But you can see that the Pfizer vaccine also worked very well if they want to receive the Pfizer vaccine again. For people who initially received the Moderna vaccine, it appears that Pfizer was the best option for boosting their immunity when they received a booster dose. But again, Moderna also worked very well. And then lastly, for people who initially received the J&J vaccine or the Johnson vaccine, they received the best boost using a mix and match schedule. And so people who received Moderna had the best boost after receiving the Johnson & Johnson vaccine, but also the Pfizer vaccine worked very well as well. I do want to mention though, in the NIH study, they used the full dose of the Moderna COVID vaccine for the booster dose. And what ended up being authorized by the FDA was a half dose of Moderna vaccine. And so some of this information might be a little different since a half dose of the Moderna vaccine is currently being used in the United States. So some other booster dose information that's important. Side effects after the booster dose appear to be similar or less than the side effects seen after second doses of mRNA vaccine. People, again, just like what we talked about with the pediatric, but people need to weigh the potential side effects of COVID illness with the benefits and risks from the vaccine. People who are moderately to severely immunocompromised and were recommended back in August to receive a third dose of mRNA vaccine 28 days after the second dose do still need a booster dose 6 months later. And so if you're moderately to severely immunocompromised, you'll need 4 total doses of mRNA, Moderna or Pfizer vaccine. And then people who previously had COVID-19 illness and were fully vaccinated may still receive a booster. And so this is data from the North Dakota Immunization Information System, but as of yesterday, over 66,000 third doses have been administered in North Dakota, and almost 31% of people 65 and older have received a booster dose. I'm happy to say that I received my booster dose. And so I hope everyone will consider if you've received J&J and it's been 2 months or it's been 6 months since you received Pfizer or Moderna, I encourage you to have a conversation with a trusted healthcare provider about receiving a booster dose. The last thing that I want to touch on is natural immunity. Last week, the CDC released a science brief on natural immunity, and that is posted on the CDC website. And so most, not all people do develop protective antibodies after natural infection. But I just want to caution people that it's likely that these antibodies are not lifelong. And so you're not going to be immune forever to COVID-19. And in one study, which was published in the Emerging Infectious Disease Journal, more than a third of individuals, 36%, who tested positive for COVID-19 didn't even have detectable antibodies when they were tested for antibodies. As I mentioned, the duration of protection is not fully understood yet, but it looks like it's around at least 6 months for most people. I would say if you're 65 and older and previously infected, I would be a little concerned if people 65 and older have that 6-month time frame. It does appear to vary from person to person and be dependent, as I said, on age, but it could also be dependent on the severity infection. So people who had asymptomatic or mild infection may not develop as great of immunity to COVID-19 as those who have more severe infection. And then also with variants, just because you were previously infected with one variant, so if you were infected back in March of last year with the Alpha variant, that does not mean that you're protected necessarily against the Delta variant. And then I also want to caution with antibody testing. One, not everybody will have detectable antibodies, and that doesn't mean that you're not protected, or if you do have antibodies, that doesn't mean that you are protected. And so we don't yet have what's called a correlative protection for COVID-19. And so antibody tests at this time cannot yet determine immunity to COVID-19. And then I just wanted to also mention a paper that was published last week in Morbidity and Mortality Weekly Report. Among adults hospitalized with symptoms similar to COVID-19, unvaccinated people who previously had COVID-19 were 5 times more likely to test positive for COVID-19 than people who were recently fully vaccinated. And so just another reason to get vaccinated, even if you previously had COVID-19, that doesn't mean you couldn't even end up being hospitalized with COVID-19 when you have a reinfection. And so definitely talk to your healthcare provider and consider vaccination. And then I just wanted to mention that COVID-19 vaccines can be administered and really should be administered with other vaccines. And so it's that time of year to get your flu shot or your flu vaccine. And so when you're going in to get a COVID booster or get your child vaccinated against COVID-19, please ask about influenza vaccine and also ask about other vaccines that you might be due for. A lot of people got behind on their immunizations during the pandemic. And so talk to your healthcare provider, ask if you're due for any other vaccines, whether that's your tetanus vaccine or your pneumococcal vaccine. And the influenza vaccine is especially important this year. We want to prevent as many illnesses as possible, especially prevent hospitalizations, so we can reduce the burden of influenza on our health system. And so if you're interested in getting vaccinated, you can go to vaccines.gov and put in your zip code, and it will show you a number of locations that have COVID-19 vaccine. You can even search by which brand you're interested in receiving. You can also text your zip code to 438-829, and it will send you back locations near you that have COVID-19 vaccine. NDvax.org has a number of clinics available. And then, of course, for those that may be less tech savvy, or if you just want to talk to somebody, you can call our hotline and we can help you find COVID vaccine and also help you make an appointment. And so that phone number is 866-207-2880. And so that is what I wanted to present today. And so I think we will open it up for questions if people want to type their questions in the chat. And while they're doing that, I did want to turn it over to, I think I'll start with Dr. Connell. Dr. Connell, did you want to make some comments? You know, the pediatric vaccine The recommendations just came out this week. I know it's been in the media quite a bit. I'm sure parents understandably have a lot of questions about the vaccine concerns. Do you want to just give some of your thoughts and how are you talking to your parents and patients about COVID-19 vaccine?
Yeah, thank you so much, Molly, and thank you and Grace for such great, interesting presentations. So that was really good data and very useful. I think one of the important things to recognize as you're making these decisions for your health and your children's health is to remember that just like with other medical decisions, you're not alone. So I guess the biggest message I wanted to provide today was the availability and the interest of your healthcare providers, your physicians, and your medical home in helping you find answers to your questions and provide guidance as you request. I think it's important to remember that we as your physicians are somewhat your consultants. So feel free to ask us questions and get the information that you need to help make the decision that's right for you and your family. So I hope you take that to heart. When families come to my office, we do lots of practice about how to approach any kind of decision. And we use the risk to benefit analysis in making those kind of decisions. And so, you know, when you think about that, this as a parent, you do this every day. And recent examples for me, should I let my son have a sleepover or be at the hotel's water park the night before the 8 a.m. game? There's a risk-benefit analysis to that. Should I take my daughter's cell phone, which is her prime means of social communication, because she was 10 minutes late for curfew? Again, another risk-benefit analysis. I mean, we do this every day as parents, right? So deciding what to do about COVID vaccine for your child is another risk-benefit analysis. And I think that's so interesting because that's how I approach it with my patients. And those are the terms that you guys use today. So nice foreshadowing. So when I ask parents if they have questions about COVID vaccine, there are sort of four main things that they talk about. One is the concern that there were only 3,000 patients in the 5 to 11 age group who received COVID vaccine. And, you know, that just seems like it's too new. We haven't done that enough. A second concern is that the concern for long-term side effects and particularly fertility. I do get that question every day I'm in clinic. And I think that comes from the fact that, you know, if you're vaccinating a 5 to 18-year-old, how would you know about fertility consequences? And that's the concern, and hopefully I can help you answer that. And then the concern for myocarditis from the vaccine, which I think Molly addressed pretty readily, but I'll share my 2 cents. And then finally, why would I put a vaccine in my child's body if they're not going to get very sick? And again, I think that was addressed well by both Grace and Molly, but I'll probably add a little bit to that. And so those are sort of the risks. And so when we think about the benefits, we've talked about the efficacy of the vaccine, and really, I don't think that's very disputable. And I think we have to understand what the efficacy of the vaccine, the freedom it brings us, and the freedom it brings our children. And for me, it was important. My mom was in the nursing home when my teenagers got vaccinated. And so that was a relief to know that my kids probably wouldn't be exposing my mom to COVID. So that was really important to me. But what was probably even more important to me was the desire to not have my kids be kept from from one more activity, to let them be able to go to every sporting event, to let them not miss one more day of school, and to feel more comfortable with them hanging around their friends and doing social things, because I felt that they were protected against COVID. And that was a really big driving force for me. I didn't want them quarantined or isolated from COVID and having to miss their sporting events and their extracurricular activities. So to be quite honest with you, that was one of two big driving forces for me as a parent. And I think that really is something that strikes my patient families. So then when we talk about the safety of the vaccine, I think, that was well demonstrated by Molly. And I think that what I wanted to add to that is this piece about fertility, because when we think, well, gosh, the COVID vaccine has only been around for a couple of years now. Well, the mRNA vaccines have been around for over 20 years, and those studies have been ongoing, and there is no concern with fertility there in 20 years with mRNA vaccines. So I feel very safe vaccinating my daughter, and I feel very comfortable in the literature. I also feel very comfortable that I don't know of a vaccine that has long-term side effects. As Molly said, most of the side effects we see from vaccines occur in the first 42 days, and not quite honestly, in my experience, it's in the first week or two. So that makes me feel very confident about the vaccine safety too. And then I think the other thing that really strikes me as a pediatrician, and this is in my private practice and at asthma clinic, is long haul syndrome. And as a parent, that was the second thing that really drove me to get my kids vaccinated as soon as possible. And that was the fear of long haul syndrome in my kids, because again, I'm going to do everything in my power to prevent any more missed days, missed activities, missed events for these teenagers and children in general who have sacrificed so much because of this pandemic. So I think what long haul is, for those of you who don't know, is it's symptoms of illness lasting longer than 4 weeks after a diagnosis of COVID. And the 6%, I think, was the number cited, is, just so you know, a conservative number. If you look at all the literature, and obviously we're gathering that data every day, there are some studies that show a much higher percentage of kids with COVID, children with COVID, who have symptoms lasting longer than 4 weeks. So I think that is a real concern, and I can share with you, between my private practice and my asthma clinic practice, I think of 3 kids. They're all athletes. One got sick in fall of 2020 and has a scholarship to college for his sport. And in spite of our aggressive management, we could not get him back to his competitive baseline by August of 2021. I had a female middle schooler who got sick in fall of 2020, and spring season of 2021, we could not get her back to her competitive baseline. And then I have one other patient who got sick in February of 2021, and his PFT dropped, and that's a pulmonary function test, that dropped to 2/3 of what it was prior to his COVID illness. And again, in spite of a lot of aggressive treatment, he struggled through his fall sport. Every practice, every game, and struggled to breathe, and obviously could not compete at his best best effort and pre-COVID effort. So watching that in 3 of my kids, my patients, I wouldn't wish that on anyone. And if you want to read a really horrible story about long COVID, I would encourage you to look at the healthychildren.org website. A mom wrote her experience with long haul COVID in her 12-year-old, who months later has regressed in all facets because she can't overcome the illness. So when we think about that, and when we weigh the benefits and risks, the benefit of getting COVID vaccine to the risk of potential adverse event from COVID vaccine, you know, for me, there is no measurement and no decision to be made. But I hope that this helps answer your questions and helps you figure out how to frame it in your mind. And again, I urge you to talk to your pediatrician, your healthcare provider, because they're the closest to you and have the very best interest of your family and you in mind. So get their opinion and get your questions answered.
Thank you, Dr. Connell. And yes, that's what we want. We just want everyone to have a conversation with their healthcare provider about COVID vaccine, regardless of what your age is. So Dr. Nagpal, we've talked about pediatric vaccine and we've also talked about boosters. I was wondering if you wanted to touch on maybe what you're seeing at Sanford and provide your thoughts on how people should think about considering a booster dose and also the pediatric vaccine.
Yeah, thank you, everyone. I really enjoyed the thorough data that you provided on the vaccine and Dr. Connell's personal stories and testimony to the effectiveness of vaccines and safety of vaccines. And I'll keep my talk short here. Let me try and share my screen. I think most of what I'll tell you is probably just reflecting the same experiences that you are sharing here. So let me see if I can share my screen here quick. So can you see my screen?
Looks great, Dr. Nagpal.
Thank you. So this is a graphic that we publish weekly. And what this shows is that the burden of unvaccinated hospitalizations on the healthcare system. So essentially, if you look at this, our usual census in the hospital is about 500. This is, numbers that reflect patient admissions with COVID-19 across all Sanford hospitals, not just ours, but for our specific number in Fargo, that's where I practice, our hospital census is usually 500, everything including. Out of that, we have about 60 patients hospitalized with COVID right now, which is 10% of our hospital capacity. We have never had a disease that involves admitting so many people for the same disease into a hospital at the same time. And that number does not count people who go on a ventilator or who have other complications from COVID, and their infectious period is over, but they remain in the hospital for a long time, either recovering from the vent or because they had a stroke or a heart attack related to COVID, and they continue to rehab from that. If you take that number into consideration, we are close to 100 people in the hospital. So quarter of our hospital capacity is directly related to, directly or indirectly related to people having COVID-19 infection, which is placing a huge strain on our healthcare system to the point that we are not able to accept patients from outside hospitals for illnesses for which they will typically transfer patients out to a referral center like ours. So COVID-19 is not just affecting people who get the infection, but it's also affecting the healthcare capacity, which is severely limiting our our capacity to provide care that people in our community need. And we are also struggling with the same job market struggles, same labor shortage that all other businesses are facing right now. Because remember, it doesn't take just doctor or nurse to run the hospital. It also takes lab staff to run a hospital, people to draw blood, people to serve food, people to provide environmental cleaning services. So we are feeling the crush here from all sides. And essentially, if we had everybody vaccinated, we would not have this problem because as you can see in the graphic here, a very small minority of hospital patients are the ones who are fully vaccinated. The great majority of patients are not vaccinated, and that contrast gets bigger as you look at patients with increasing severity of illness, whether they are in ICU or they are requiring ventilators. And the common questions I get when I counsel patients about getting a COVID-19 vaccine is that why should I take a vaccine? Because I'm otherwise young and healthy. I watch my diet, I exercise regularly. I don't have any of the risk factors. So why should I take the risk of getting a vaccine? Well, to that I say that death from a disease is not the only measure of efficacy. As other speakers have already pointed out, there are other effects related to COVID-19, significantly 10 days of quarantine, job loss, loss of paycheck, family members getting infected, your other elderly family members getting infected, and the other complications of COVID-19 besides respiratory failure, like having a blood clot in the leg or blood clot in the brain or blood clot in the lungs, or having renal failure requiring dialysis, or having a heart attack because your oxygen level is very low in the blood, so you're not getting enough oxygen supply to your vital organs. Plus, the syndrome of long-haul COVID. This is a study that was published in Morbidity and Mortality Weekly Report recently. And what you see here is even after infection, a significant number of people do not return to their baseline. So even after 2 months of illness, a number of people, 35% of people continue to have some symptoms related to COVID-19, whether it's loss of taste or body aches or loss of smell or persistent fatigue, headache, other respiratory symptoms, brain fog. These are the common symptoms that we continue to see even after your infectious period is over, and this may limit your ability to work or to enjoy your daily activities outside of work. One of the things that we were not seeing last year was too many infections in the kids, and I think that's not because COVID doesn't affect kids very much. It was because we protected our kids well last year. We had a lot of social distancing, masking. Many of the businesses were requiring masks. Many of the businesses were operating at decreased capacity, and the schools were remote or hybrid. So what that happened was that artificially reduced the rate of infection in the kids. But if you look at way things are right now, we obviously need to get some kids back in school, and we have done that. And all the businesses are open, and the mask requirements are not as strict last year. So what you see here is a more normal epidemiological curve, which shows that children are getting as affected. Obviously, young adults are at higher risk of exposure just because they are the ones who are out in the doing jobs which require direct interaction with other people. So their risk is higher. They get the most infections. But at the same time, if you look at how this age distribution looks like. This is directly from the North Dakota Department of Health website. The age distribution is looking fairly normal, like it does for other respiratory diseases. Kids do get sick. We have had in our hospital about 28 admissions related to COVID-19 in children, and about 12 admissions related to MISC. And some of those have been severe enough that we have had to transfer those kids to a higher level of care to require, because they require either non-conventional ventilation or a heart-lung bypass machine called ECMO. And the vaccination does prevent these kind of complications in kids. And 28 and 12 may not look like huge numbers, but you have to remember that between the 3 campuses that we have in the Fargo region, we have about 14 floors dedicated to the care of adults and only 1 floor dedicated to the care of kids. So that 28 number is actually a very significant number if you consider how many pediatricians or pediatric specific nurses and other allied health professionals we have working in the hospital. So smaller numbers in pediatric age group do stretch our resources. And this next slide shows you the difference, population level based difference between the risk of acquiring risk of complications from natural infection versus risk of complications from the vaccine itself. And this is a study of 1 million people out of Israel. So I challenge you to find another study on any kind of medication or any kind of product across any industry, which looks at 1 million people who have had either a natural infection or a vaccine, and it looks at which is more dangerous and which is more beneficial, and it's not even a comparison. You know, cardiac rhythm abnormalities, blood clots in the legs, blood clots in the lungs, kidney injury, which is renal failure requiring either hospitalization or need for dialysis. So all of these are, the risk of all of these are significantly elevated with a natural infection. So death is not the only measure of severity of COVID-19. The one thing that happens more frequently with COVID-19 vaccine is something called lymphadenopathy. This is actually a reassuring and natural phenomenon. What this means is that your lymph node is swollen, typically on the side in the armpit, where on the arm which you get the vaccine. And this is reassuring, which means that this shows that your body is actually mounting an immune response to the vaccine. So it's not something that impairs your ability to do anything. There's a lot of misinformation out there, and one of the things that I saw this in the past couple of weeks was increased number of deaths after the vaccinations were introduced, but that's not true. We study vaccinations very carefully, even after they are completely FDA approved through our vaccine adverse events reporting system, which is a robust tool to detect post-approval side effects of the vaccine. And we, as Molly already said, that we have had administration of more than 250 million vaccine doses nationwide, and we continue to follow these very closely, and we have not seen any significant increase in deaths. If anything, vaccine has lowered your incidence of other diseases like heart attacks and strokes. And that may just be because of chance alone. I'm not saying that's a bonus of getting vaccination, but what it shows is that the risk of death following a vaccination from any cause, not just directly related to vaccination, from any cause, is not increased in a real world setting. And there's a lot of misinformation out there about infertility related to vaccine, and this was published in New England Journal of Medicine. What this slide shows is that among 36,000 women who got the vaccine during pregnancy, or they got pregnant soon after getting a vaccination, the rate of spontaneous abortion, stillbirth, preterm birth, or congenital anomalies, or neonatal death, or smaller size for gestational age, they were all same as the baseline rate of the population. So no increase in any of the outcomes of interest during and after pregnancy if you receive the vaccine. And I think that's all I have. Thank you very much.
All right, thank you, Dr. Nagpal. Also good information. We do have a couple of questions that I wanted to ask you. First of all, probably Dr. Connell, what advice do you have for parents that want to wait and see about the vaccine? You know, this is a new vaccine and they want to wait a month or 2 months just to see what happens when more individuals are vaccinated. What is your response when a parent asks you that?
Well, so it's interesting because historically, and you might get mad at me, Molly, but with meningococcus B vaccine, you know, the typical phase 3 clinical trial actually does involve about 3,000 people, like the Pfizer 5 to 11-year-old COVID vaccine trial. And so at the end of the meningococcus B trials, there was just this little bit of question about neurologic side effects, specifically Guillain-Barré. So those of you who are my patients know that I said, let's just sit tight on this, wait till your child gets closer to college, and then we'll wait and see. And for my own kiddo, who was, I think, 19 when that vaccine came out, I said, nah, we're just going to wait a little bit longer. So I don't think that vaccine has been given to the degree as not as many people have received it as have received COVID vaccine, which worldwide, by the way, is over 400 million people 12 and above. But finally, enough, a million people or more had received MenB, and I felt very comfortable. And so my 17-year-old daughter received MenB vaccine, and I'm now recommending it to my patients routinely. Okay, what's different? Here comes that risk-benefit analysis. So the difference between that situation and COVID vaccine situation is the chance of getting meningococcus B is rare. The problem is if you get it, there's a fair shot that you might die. And so that's that risk-benefit analysis. But I felt the rare chance of getting it bought us some time. The situation with COVID is not that. I've heard from Dr. Paul Carson, who I think many people know. He's another one of our infectious disease heroes from North Dakota, along with Dr. Nagpal. But just this morning, I watched something from Dr. Sean O'Leary, who's an infectious disease pediatrician who is actually a residency mate of mine, and he is the American Academy of Pediatrics representative for COVID. And both of those infectious disease experts agree. It isn't a question for unvaccinated people of if you get COVID. With Delta, it is a question of when you will get COVID. And so that changes the risk-benefit analysis significantly. And that's why I say, if you're concerned about your kids missing any more days of school because of quarantine from exposure or isolation from getting sick, if you're concerned about the rare but possible side effect of MIS-C, if you're concerned about the very real consequence of long-haul COVID, which I think is very common, then you should get your child vaccinated.
Right, thank you, Dr. Connell. I'm going to put you on the spot, Dr. Nagpal, so tell me if you don't have comments on this, but you know, there's been a lot in the media today about the Pfizer medication that's potentially going to be available in the near future to treat COVID-19. Did you want to provide any comments on that? And then what does it mean that we may have a medication to treat COVID-19? Should people still consider vaccination even when there's a treatment available?
Yes. So, there was this press release by Pfizer today about their antiviral medication, which looks like is a combination of two antiviral medications in the class, something called protease inhibitors. That's a class of medications, and we use that frequently for treatment of HIV and hepatitis C. And looks like, according to the numbers they released today, that it's very effective if given early in the course of the disease. And that's a potential game changer because we want, the pandemic is here to stay with us. It's not going anywhere. So the challenge immediately before us is to make this an outpatient ambulatory disease, which we can live with and reduce it from being a severe life-threatening disease to something that's manageable with vaccinations and with medications. And right now we have some tools to do that in terms of monoclonal antibodies, which reduce your risk of hospitalization and developing complications, but they come with some disadvantages in the sense that you have to have the patient come in and do an IV start. It involves nursing staff. Patients have to stay for an hour after getting the infusion, and it's in limited supply. And it requires a lot of resources. Then it involves travel or somebody to bring the patient to the hospital if they are not feeling well. So even though they are good tools right now, we can have better tools, and the better tool is obviously an antiviral pill, which will obviously help us mitigate a lot of severe cases of COVID-19. And they still haven't submitted the data to FDA. It was a press release today. So typically, after you submit an emergency use authorization application to FDA, which is a very transparent process, just like it is for the vaccine, it typically takes them about a month or two to go over it and then issue their emergency use authorization or full authorization, whatever the case may be. So I think it's still about 2 months away. A couple months away, 6 to 8 weeks away, I would say. So by early next year, if everything goes according to plan, we do expect that pill to be another tool for us against COVID-19. And I won't rely solely on that. Because what we are seeing with monoclonal antibodies also is that if you are vaccinated and then you get monoclonal antibodies, your symptoms are much less severe, much less in duration, significantly reduced risk of hospitalization. So, we don't have a perfect tool against COVID-19, but with a combination of tools, we can make it a routine respiratory virus, and we are close to doing that. We just need enough vaccine uptake, and we just need to be patient for the regulatory agencies to do their job and look at the data carefully. What we know today is the number of people who got prevention from hospitalization or death from this new pill that Pfizer has been testing, but we don't have the safety data yet. And to vet that thoroughly, let's give our regulators some time to do that, so that we have confidence in prescribing that pill.
Hey, Molly, can I piggyback off of that?
Mm-hmm.
So Dr. Nagpal, I liked how you were talking about the multimodal approach to the respiratory viral disease. And I just want to again compare this to influenza. So for influenza, we have vaccination and we have Tamiflu or other things like Tamiflu. And I just want to use this to point out that the 2 years leading up to the pandemic, with those modalities in place, we had 343 pediatric deaths from influenza. And again, that's the 2018-19, 2019-20 influenza years. Since the start of the pandemic, which is technically less than 2 years, we've had 680 pediatric deaths from COVID. So it's my hope that with those added modalities, when they're approved for kids, you can't use monoclonal antibodies in children less than 12. And this Pfizer pill will not be available for kids less than 18. So it's going to take a while for those modalities to be available for kids. So right now, the only protection for kids is vaccination.
All right, thank you. And I think we have to wrap up. We went a little over today, but hopefully it was good information for everyone. I want to thank our presenters and participants today. Again, we just want everyone to have an open mind and talk to your healthcare provider and get your questions answered about COVID-19 vaccine, whether it's for yourself starting the vaccine if you haven't had it yet, whether it's about a booster or about vaccinating your children. And then we encourage you to go to our website for more information. And we will have additional town halls in the future on topics. I'm sure, you know, if there's treatments approved, we'll be providing additional information. This town hall will be archived on our social media and will be available on our YouTube page for viewing at a later date. But thank you again for everyone who participated today. And again, just please consider taking steps to prevent COVID-19 in you and your family. So thank you.